Please, can you actually notice? Sounds like it.
Yeah.
No.
Good seeing you. I wish I drank tea. Thank you. I get myself.
You know what? It's actually not. I wasn't sure. I didn't realize that. So we only started signing. Yeah, there's going to be three. So there's just like so it's
Yeah, depending this morning I think it depends on where.
I mean there's
Right. But I mean,
that's true. That's true.
I'm
gonna put everything on folder 2. Okay.
I'm not gonna understand the words that are coming in. I trust you. Just put the files in and then that up there.
Yeah, so how it says 0,
I do see that.
nothing recorded. Whereas folder 1 has a list of files, so it's not gonna touch folder 1 because I don't know what's in there. And then so go with folder 2.
I like it.
Essentially, record. I'll do it for the first time.
So I have to end it.
So just hit history. And it'll say accessing file. And then it'll replay. And then I believe there was one way to put it in your computer was that for another thing. For another thing.
Then just
I don't know how you
I want to go look at that wall.
transfer. Oh, you wait.
I want.
Okay, zero.
Someone say it.
I think Ellie.
Yeah.
The folder was setting.
Oh, good. Yeah.
Can I give them things back to like understand? Like right now, I feel like I need to. Yeah.
I'm on it. Oh, yeah. I need to make sure that we were the right thing, which I've described.
We'll see who goes.
Yeah. Hi, we're just kind of getting settled in here.
I am doing okay. I was one master.
Yeah.
So as far as we know, I don't think we can kind of get started. I just don't know.
Hi, I'm Suzanne from South Shore. I just want to introduce myself. I know we'll see you tomorrow. I just wanted to kind of like walk these. I figured I'd kind of grab you. Very important question about it. So good for you.
Yeah.
Yeah.
Oh, for the one, yeah.
It's
I'm sorry. We should be able to share.
Morning, how are you?
Good, thanks.
Yeah. Yeah, it's very technical and it's all read off material.
Morning, sir. All right, I'm good.
Yeah, well, this is having tab, so that's the first part, and then they let them go, and then I started and just kind of see what I can play.
We think mobile grading is going to help. We think obviously it's a little bit just closing on how to express this week. And then closing things kind of go off. They're now officially under the South Shore umbrella.
And they're
Currently integration, like they are part of this now. There's other pieces that, you know, I will.
in this case.
The hospital should work to take care of the sick. It's really moving more services than I guess.
Yeah, I think we've got.
They're like, we're trying to. So I think like because I mean everyone has been all the all the others
Good morning, everyone. It's nearing final exam time, so if you'll all put away your notes, bring out your blue books and pencils, we'll get started. Ron, would you like to pose the first question for the brief on final exam? I hope everyone had a lovely Thanksgiving holiday. Today we have a number of issues to discuss, and as you can see, the slide deck is fairly full. So I think what we will do is just dive right in. I think the first thing that we have to do, David and I, that we have a quorum to do this, is to get the minutes from the last meeting. So the minutes were circulated, and I guess I should first ask if anyone has any changes they wish to make to them. Then is there a motion to approve the minutes?
So.
In a second?
Second.
Okay, all those in favor of approving the minutes?
Aye.
And any in opposition? Okay, thank you. Elizabeth is on the phone. Good morning, Elizabeth. And you just feel free to yell at us when you want to dive in, because sometimes I will forget that there's a phone just sitting here at the table as well. Therefore, the minutes are approved. I think we want to do a few different things today, so you can see up on the screens the things we want to do. One is the RPO filing requirements. Second is talk about the PIP process, and in particular the closeout 2018 closeout, and then the 3-year recap. And I think that will hopefully lead us to do is to have a general discussion about how we think it's going, what changes after 3 years we think we ought to make or we would like to make, or anything like that, things that we think are going well, and things we think are not going as well as we'd like them to go. And then third is the healthcare cost trends report. David, is there anything we should do before, anything you want to say by introduction before we dive on it?
No, other than to say we are, this is a preview meeting in some cases for our next board meeting. So our next board meeting is 2 weeks from Thursday, December 13th. And at that meeting, we're going to be going through all of the findings from the cost trends report. So what we have for you today is one piece of analysis that we did as a little bit of a preview, but expect that we're going to have a full board meeting dedicated to the cost trends report and a lot of different findings coming up soon.
And I imagine that will also include some wraparound from comments that everyone made at the annual hearings in October, which clearly are reflected in then what happens in the cost trends report, and then sets us up for where we want to go from here. So I think it's a natural sequencing of everything. Very well then. I think if I understand the sequence correctly, I turn it over to Kate, who then goes to the LPO filing.
Great, and actually, because Kara Vidal, Senior Manager on Market Performance, actually oversees both the Registration and Provider Organization Program and the Performance Improvement Plan program on my team. I'm actually going to have her do most of the talking, but I will chime in, I'm sure, throughout. And Ramsey Hoge, who's one of the key analysts in particular for the Performance Improvement Plan process, will join as well.
Karen,
Thank you very much.
thank you very much.
Didn't know it was final exam season, so I do have a lot of notes with me.
We'll let this one be open book then.
Excellent, thank you. Great, so just on the RPO program, very briefly, we are in the process of collecting our 3rd year of data, which seems like quite a milestone. The team is almost wrapped up the 2018 filing. They should have that data available on our website very soon for the many organizations who we know are using it. And there's no rest for the weary. At the same time, they are preparing for the 2019 filing, which is due to take place in the summer of next year. And on Monday, released a memo outlining a few areas of expansion, new data elements that are being proposed. You'll recall that we have been rolling out those requirements over time rather than requesting several categories of data in the statute all at once. We've been adding those in as we go. We did not add any new data elements in 2018 for a couple of different reasons, primarily because many of our organizations were preparing for the implementation of Mass Health ACOs in the spring. And with a summer timeframe, we decided to give them a break for a year. They reported the same information. So in 2019, we are including a few areas in our proposal for expansion. Those include updating an existing question about Medicare facility fees to include more payers, capturing some information about inpatient and emergency service availability at hospitals and clinics, requiring a roster of employed advanced practice providers, physician assistants, and advanced practice RNs, which will help us better understand workforce and staffing patterns. And finally, collecting some information on physician payer mix, which is meant to complement CHIA's existing hospital payer mix collection. So that and many more details are available in the memo, which is on our website, and we are receiving comments through the 21st of December.
How much additional work like in your informal sense, is this sort of a lot of additional work, a moderate amount, a trivial amount of additional?
It depends on the question. I think the first two on facilities are hopefully going to be very, very minimal, particularly because we're hoping that on the service availability piece, staff can pre-populate that with DPH data and just have providers check and confirm for us. The APPs we know is going to be a little bit more work, but it is an area that almost all of the end users of the data have highlighted as particularly important. And the physician payer mix is hopefully going to be in between those two. We think it'll be not quite as much as the advanced practice providers, but obviously a little bit more than facility fees. But that's certainly something we'd like to hear about in the comments. And if there's much more to any of this reporting than we think there is, helping us understand exactly what has to be done and why something would be difficult is helpful so that we can then go back and think about whether there's a better way, an easier way to collect the information we need.
And just to highlight that really quickly, in particular, the types of comments that we've found very helpful in the past are comments that, if this were worded just slightly differently, it would be so much easier to do. If you collected this on a slightly different time frame, it would be so much easier to do. So really have found that feedback incredibly helpful and would invite all reporters to think about that type of feedback.
I just wonder if you could comment on provider compliance. Most or all compliant, and and what if they choose not to? Right?
Compliance has been very, very good so far. We have almost entirely complete data sets, but in 2018, they're wrapping up the process. If a provider did not comply, we do have a statutory penalty which says they can't contract with payers, which is quite a hefty penalty, which we hope to never have to use and have not had to use so far. Yeah.
Thank you.
Thank you, Karen.
With that, we will pivot to performance improvement plans.
Wonderful. So as you mentioned, Dr. Cutler, this year the Commission completed its third annual review of payers and providers who had been referred to the HPC for their cost growth and were therefore eligible for a potential performance improvement plan. So another very big milestone. But as you know, per statute, much of the PIP's work is confidential. The entities of those payers and providers cannot be revealed unless the board were to require a PIP. And therefore, a lot of this work has to be done through executive session and in confidential meetings. So this is an opportunity to provide a public recap of that process and share some of the major themes that the board has been discussing, but that haven't necessarily been discussed publicly in a few years. So just as a brief reminder, as you know, PIPs are one of the key tools that the HPC has for enforcing healthcare cost growth benchmark. Payers and providers are referred by CHIA to the Health Policy Commission based on their health status adjusted total medical expense trends, HSA TME trends. The HPC then performs a comprehensive review of each entity's spending and may choose to require a PIP if the Commission identifies significant concerns about the entity's costs and determines that a PIP could result in meaningful cost-saving reforms. That's sort of the standard that we're using. And a PIP must address the causes of that cost growth and include action steps, measurable outcomes, and implementation timetable of no more than 18 months. Any questions on that? Great. So, as you know, the Commission has not yet required a performance improvement plan, so only steps 1 and 2 on this chart have been completed. But were the Commission to require a plan, we would then proceed to steps 3 through 6. So a healthcare entity would then submit their proposed PIP, and the board then has to vote on whether or not to approve the PIP for implementation.
If the board approves it, the entity then progresses immediately to implementing the PIP, which includes regular reporting to the commission on its outcomes. And at the close of a PIP, the board then has to vote on whether or not the PIP was successful. If the PIP was successful, then it is complete. If not, the commission has a few options, including extending the timetable, requiring amendments to the PIP, requiring a totally new plan, or waiving or delaying the requirement for an additional PIP. But as those steps have not yet taken place, the rest of this presentation will focus on steps 1 and 2 of that process. This slide should look familiar. This is the methodology that CHIA has been using since 2017 to refer providers to the HPC. And just an important reminder, CHIA applies this standard to specific contracts. So this is not an evaluation of the entity as a whole. This is an evaluation of each of a provider's contracts. So what they look at in the first pathway is, did the contract have health status adjusted TME growth above the benchmark? So 3.6% so far, although that will decrease to 3.1% when they're looking at 2018 trends. If yes, the entity is referred, even if the entity only had that growth in one of its, say, 5 contracts. The second pathway is applied the same way, but it's meant to capture the fact that some entities, due to their size or due to their baseline spending, may have an outsized impact on the spending of the Commonwealth as a whole. So CHIA added this pathway in 2017 that says if the HSA TME growth of a specific contract was at 85% of the benchmark, which is 3.06% currently, and the entity is very large, and either had a high baseline level of spending or had high unadjusted TME growth, that contract and therefore the provider will also be referred.
And just as a quick reminder, I know we've spoken about this many times, but for the benefit of the audience also, just to refresh your memory, total medical expense is all of the spending for the patients with a PCP with a given provider group. And so that is not only spending at that organization, it's spending at other institutions, other hospitals. It includes pharmaceutical spending. And as you see here, it is health status adjusted, and much more on that later in this presentation.
Much more. This slide is the referral methodology for payers, which you'll see is very analogous to the provider slide. So important to note that CHIA's referral methodology is very quantitative, it is very strict, and it is done on a contract by contract basis. The HPC then performs a much more comprehensive review of the entity as a whole. So even if a provider or a payer was only referred for one contract or one book of business, we then look at all of the data that we have available on that entity to put that specific contract in context. So the metrics on the left of this slide are the things that we look at for every entity that is referred to us. So that includes all of the TME data, adjusted TME, unadjusted TME, risk scores. We look at the level, the growth, comparison to their peers. We look at the entity size and market share. We look at their relative price. We look at whether or not the entity has appeared on CHIA's list previously. And as time goes on and there are more and more lists, I think that's going to become a more important factor than in the first few years. And we also look specifically at factors outside of an entity's control. Is there a reason that their cost growth went up that has nothing to do with their pricing or their utilization management? Is there some outside influence that they shouldn't be being knocked for? We present all of that information to the commission, and then you help us identify areas where there are further questions that need to be answered that we can't answer from the data alone. And those are the entities where we do follow-up. And the follow-up meetings either occur in person or over the phone, but focus on those specific questions that the commission raises. And we ask for more information from the entity. The one thing that we ask for across the board from everyone is, why do they think their spending growth was high? what is going on internally that they can see in their own data, and can they provide data to us that backs up that story. The other metrics on the right-hand side are things that we have asked from probably most, if not all, of the entities. Care delivery and other strategies to control spending, rate increases, the role of pharmaceutical spending has been consistently brought up. I think even if we did not ask for that, it probably would have been included in the entity's explanation for spending growth across the board. Data on their patient population, referral patterns, et cetera. We then analyze that, we bring that all back to the board, and you determine whether or not you think your questions have been answered and whether or not a pivot is warranted. So looking at the 3 years of data that we've had so far, just a quick reminder that in 2016, CHIA was using 2 sets of data to do their referrals. They were using 2012 to 2013 final data, as well as 2013 to 2014 preliminary data. Based on public comment, CHIA then revised that method going forward to only use final data, which is why the number of referred entities in 2016 is higher than in 2017 and 2018. If we were to take out those 2013 to 2014 entities, the numbers dropped to, I believe, 16 providers and 4 payers in 2016, making those numbers look much more stable over time than I think they do on this slide. On the next slide, you can see the number of contracts for which each provider was referred. This slide looks specifically at provider contracts. And you can see that the majority are referred for only 1 contract, and that percentage has actually been increasing over time. So it was 62% in the first year, it was up to 85% in the most recent cycle. And I think that's great. I think that's an indicator that we don't necessarily have providers who are flaunting the benchmark, who are taking no steps to control their cost growth. When entities are referred to us, it's usually for a single contract in a given year. I think that's helpful.
Just to reinforce that, many of these particular contracts that we've seen are very small.
Mm-hmm.
And so with small numbers come the potential for outliers to drive things.
Yes, yeah, that's also very
Many of them we've sort of found it easy to set aside because, for example, it's sufficiently small that 2 or 3 claims for a particularly expensive item would drive spending in that time. So I think I think it's good that we do that, and I also think it's good we don't ask the organizations for explanation of those because they'll have to search through their records to find out that people had hepatitis C or whatever it was that then led to very high levels of spending in that contract.
Yes, that's right. We do try to answer these questions or determine that the contract itself is just not large enough or the spending growth not high enough to be concerning, so that we're not asking for 25 explanations. That's a great point. Thank you, Commissioner Cutler.
Can I ask one question about the kind of the data lag? You know, this year in 2018, we're looking at 2014 to 15, which seems kind of like ancient history in a way, but I know it. Because we talked about this, it's the most recent that we have. But will we ever bridge that gap? Do you think we get a little closer?
I don't know if we'll bridge the gap. It is the most recent data available. That's final. We could look at a 1 year more recent, 2015 to 2016, but then we would have to look at preliminary data based on the sufficient timetable right now that payers submit to CHIA based on. If CHIA were to require that data at a different time in the year, we might be able to get a little bit closer. I don't know if it would be significantly closer. And I know that CHIA uses the timetable they do so that they're able to publish their annual report in September, which then leads up to the cost trends hearings in October and the cost trends report that the HPC puts out. So I think there could potentially be a slight improvement in the timeline, but it would probably only get us 1 year of more recent data. Or preliminary data could be used, but I think the market made clear that they prefer the use of final data. Ramsey, you looked last year at how much the data swings from final to preliminary, and certainly share the findings there, but my recollection is more than we would like.
Yes, that's correct. The data do change from preliminary to final.
And just to add very briefly on this, so we have now finished the review of the 2017 list that came to us at the end of last year. And so the 2017 list was the 2014 to 2015 final data. The 2018 list, we are not talking about, but in 2018, that review will be of the 2015 to 2016 data. Just to clarify that it's still a time lag, it's not quite as much as that. And obviously, as Kara noted, in the first year of its referrals to us, CHIA did use that preliminary data. They backed away from it, in part based on feedback that folks didn't feel that preliminary data was reliable enough to use as a basis of referral. That said, we do look at it in our process.
That's right, we do look at it, and we certainly invite the entities in the follow-up meetings to share anything more recent that they have internally that they're willing to share with us. And many of them do, and often it's enough to see that a troubling spike was in fact a spike and went back down in the subsequent year. So certainly we don't shy away from inviting people to share whatever they can with us.
The time lag is one of my frustrations with the process, because we're looking 2 or 3 years later, and we know things have happened in the intervening time period, and we're just not able to take account of that. And so I don't know what we can do other than keep encouraging CHIA to be able to move these data through to completion as rapidly as they can. I know they're working super hard on it, but it just makes it very difficult to be working with data that are old, where often there have been fairly material changes in the intervening time period that we're just not able to accommodate.
But David, I do want to bring to fore the idea that when we finally really review a particular entity and they come before us, they bring more recent data. So I think it's important everyone understand that we're really, at the end of the day, not using alone the old data. I think it is a legitimate area to be concerned about, but as this is played out, not only do we get more data that's, while not complete, more closer to the current, but then if we ever want really, and as we have done several times, brought entities to us, they're surely going to bring data that says, okay, that was 2014, but in 2016 we're really under the cap. And so I think everyone ought to understand it's a problem, but it's not something that really totally obliterates the process. Is that fair to say?
I certainly think it's fair to say that.
Yeah, that's an excellent point, Chairman. And just to highlight in particular for folks in the audience who don't see the inner workings of this process, the initial referral to us is really the first step in a very robust review process. So one of the reasons why we're talking to you about kind of the closeout of the 2017 process is that we spend the better part of a year analyzing all available data sources on each of these entities. We do many hours of briefings with our commissioners. We assemble huge binders of data, and so just as Chair Altman highlighted, that is certainly not limited to the HSA TME data.
Okay, so the next slide shows the contracts that have been referred to us. Again, this is just provider contracts by insurance market. And you can see that it is primarily commercial contracts that are referred to us. I think there are a couple potential reasons for that. One is that unlike in Medicare and Medicaid, the commercial market has greater ability to see rate increases that can drive spending increases. There are also winding down of some other products that made up some of the referred contracts in the past, like Commonwealth Care. I do think that it's important to note that there are not necessarily the same number of referred contracts from commercial, Medicare, and Medicaid. So it's not necessarily that the commercial contracts are performing worse than the other contracts. We may have more of them in the data set to begin with as well. From there, our plan is to jump into the 5 themes that we think have been consistent over the last 3 years. Those are data reporting issues, rate increases, care management strategies, pharmacy spending, and then the last one we'll touch on, health status adjustment, masking spending growth. Any other thoughts or comments before we dive into those themes? Great. So the data reporting issues we have seen in every one of the 3 cycles so far. The TME data are reported by payers to CHIA, and they are used to evaluate both the payers' spending as well as provider spending, which means that when there are data errors, they impact not only the entity who reported them, the payer, but also all providers who have a contract with that payer. So they are certainly frustrating on a number of levels, and they contribute to the data lag issue that you mentioned earlier, which is that often we get the data, or I shouldn't say often, I think in every case that we've seen these data issues, we have worked with CHIA to have the data resubmitted correctly. But by the time we get that data for both the provider, the payer, and all of the providers with the contract, the time lag is even greater than it was before, and the referral has already taken place. So sometimes we find that with the updated data, there are providers who should have been referred but were not, or should not have been referred and were. And so these data reporting issues are significant and really impact the process. And CHIA has been a great partner with us over the last 3 years in working to get these submissions updated correctly, and have often identified the data errors on their own end beforehand, but have been unable to get these payers to resubmit until they get a notice from the HPC saying, hey, we're considering you for a performance improvement plan. So this has certainly been a problem, and hopefully will not be a problem moving forward, but is something that's impacting the process.
And just to note, as you see in the last bullet here, 4 payers over the course of 3 years have been required to submit corrected data for this process. So it is certainly concerning to us that every year we've had at least one payer that has had to resubmit. That said, I also do want to emphasize that the majority of the data is coming in correctly. This isn't meaning that most of the TME data is incorrect, but every year we are having to go back to one payer, and it's a different payer every year too.
Right. The second theme that has come up consistently is the role of rate increases on spending growth. So we ask entities both about their historic rate increases and the impact of those increases on spending. And while we only get data from those entities that are before us in the PIP process, and specifically only those for which the board has recommended follow-up, we have observed a number of cases in which providers receive rate increases that are above 3.6%. So we know that healthcare cost growth benchmark is not acting as a firm cap in all cases on these rate increases. And these are concerning because when rate increases themselves are at or above the benchmark, that leaves no room for spending growth based on changes in utilization or service mix or provider mix. So that's something that we have been doing quite a bit of investigating through this process. That being said, we do try to put those rate increases in context and recognize the differential impact that a large rate increase can have for a smaller provider versus a larger provider, or a relatively lower priced provider versus a higher priced provider. So we do look at those pieces as well. Certainly the role of care management strategies is something that comes up often. I think almost every entity that we followed up with has been implementing strategies and have been eager to share those with us. There are several examples on the slide of what folks are doing. I think one area that has been frustrating for us is that often these programs have not always been closely and thoroughly tracked. Not all providers or payers have the same ability to collect data on these efforts and robustly and in real time analyze their impact on spending growth. Luckily, we have a few teams here at the HPC that have developed quite a strength in doing exactly this work, developing, implementing, and tracking the results of care management strategies. So we're hoping in the future to be able to refer these entities to some of the great resources that our colleagues on the care delivery transformation team have been developing and providing. Pharmacy spending, I think, is probably very familiar to everyone here. It's been a theme not only in the PIPS meetings, but in the HPC's cost run reports, in CHIA's annual reports, and just across the board is a known driver of spending both in Massachusetts and nationally. Almost every entity that we spoke with pointed to pharmacy spending as a contributor. Almost all of them pointed specifically to new Hep C drugs coming in the couple of years that we've been looking at so far. Although, as you can see on the slide, there are other things that can cause pharmacy spending to go up in a certain year and then come back down. So not only the introduction of new drugs, but also changes to formularies or coverage, contract renewals, both payer-provider contracts and payer PBM contracts. And across the board, entities have strategies in place to address those costs, but their efficacy is sort of competing with these other factors like the new drugs and formulary changes, contract renewals, etc. And then the final theme, which is the last item in this presentation for today, and certainly an area where we'll hope there'll be some discussion, is on health status adjustment masking spending growth. And this is not a theme that is specific to entities that have been asked to do some follow-up with the HPC through the pitch process. It's much broader and applies both to all of the entities on the list that we received from CHIA and entities who are not on the list from CHIA. And that is that the healthcare cost growth benchmark, which is the goal that we as a Commonwealth are all driving towards together, is measured in total healthcare expenditures, THCE, which is a reflection of real dollar spending. Conversely, CHIA's statute requires that they base their referrals to us on health status adjusted total medical expense, HSA-TME, that acronym that keeps coming up. HSA-TME does not reflect actual dollars spent. It's an efficiency measure. It starts with unadjusted TME, which is a reflection of actual dollars spent, but it's then adjusted based on patient characteristics, primarily age, sex, and diagnoses. And it's very important as a policy tool because it allows us to compare across groups by adjusting for changes in the population. Certainly we would expect a provider or a payer with a much sicker population to spend more per member per month than a provider or a payer with a very healthy population. It also discourages cherry picking of healthy younger patients by these groups and helps ensure that there's not an access issue for older, sicker patients. However, what it means in this case is that an entity could have very high growth in their actual dollar spending and not be referred to the HPC through this process if they also had high growth in their risk score. So I'm a very concrete thinker. I always like an example. So this slide illustrates exactly what that looks like in the data. These are made up numbers, just a sample. But if you look here, you can see that unadjusted TME, which reflects actual dollar spending, can grow by 8%. But if a risk score were to grow 6% during the time period, which I believe I made up some numbers, and then Ramsey, the analyst, came in and said, why don't we use some actual numbers that are closer to, well, not actual numbers, but numbers that are closer to reality. So this is a very reasonable scenario that we see all the time in the data. You see when you divide the unadjusted TME by the risk score, you get the health status adjusted TME. And in this case, it now looks like it's only grown 2%. And that growth rate is the rate that CHIA has to use in its referrals. And as we talked about in the methodology slide, 3.6% or 3.06% with some other qualifying factors is the basis for referral. So even though we have 8% growth in spending here, we wouldn't see this contract referred to us.
So, Kara, this requirement of CHIA is in the law?
yes,
But it could be modified or adjusted by, but it has to be adjusted in the law.
correct. That's correct.
And I'll note that the statute, their statute does say health status adjusted TME. They have defined that in a certain way. I mean, there could be some room there. It does certainly indicate though that they should be using health status adjustment broadly in determining who
Now,
gets
do they
referred to us.
provide us, I think I know the answer, but do they provide us with both?
Yes, so we have those raw spending numbers. It's and as I said, we look at all of the data points that we have available
And
to us.
we're not required to use the adjusted, or we can use both.
That is correct. However, we do not require a PIP from anyone who is not first referred to us.
Yes, no, so in other words, yes, right, so we may never see technically an entity that has exceeded the actual spending growth. But to the extent that we do see one, because it goes in both directions, so it's a half-y loaf kind of a situation.
Correct. And so this sample calculation is one of an example of an entity that would not be referred to us. And so we could look at their unadjusted TME, look at that risk score, have concerns, and the PIPS process would not actually give us an avenue to follow up with them because they would not be referred to us under the SHIA referral methodology.
See, unlike the data, the time issue that we talked about before, which we can somehow modify and later, this one is harder to deal with unless we see some kind of changes.
Possibly we should recommend a change.
Yes, that's exactly.
And how strict are the policies around the algorithms where you calculate a risk score? This is all self-determined by the institution or the physician.
These are the payer health status adjustment
Right.
tools, so they're using them across
they're
their
using-
entire payer network. So it's the same tool that payer A would use across all of the providers in its network.
But they're getting the data from the provider, right?
Correct. So the
Yeah.
providers could, for example, diagnoses which
Right.
feed into the risk score algorithm, which create a health status adjustment score.
A good question about what guardrails there may be in place. I don't know that we know that. We know that the payers can use different tools. They're not all using the same tool. Even when payers are using the same tool, there are different versions. They can make adjustments internally that they think are optimizing the tool. And I don't know what exists in terms of guardrails saying you can do this, you can't do that, but that's certainly a great area for us to look into to see if there is anything there.
What role does the provider have other than providing specific data on the patient?
They typically are not calculating the risk score in any way. They are,
But they're providing the data
that's right.
where the risk score does get calculated.
That's right.
So
And
the higher the risk score benefits the provider as well.
typically it does, specifically in risk contracts, for example, where they are working against a budget that might be health status adjusted, although we understand that, excuse me, we understand that payers have incentives also to maximize risk scores under the Affordable Care Act, and that they can often shield themselves from some of the costs associated with rising risk scores by normalizing the risk scores and just keeping providers compared to themselves. So if everyone's risk score goes up 5 or 6%, they can say, okay, an increase in 5% is the new normal. That's now baseline 0. And we'll just look at how providers differ from that new normal rather than having to pay out a 5% increase in the budget necessarily. Thank you. Thanks.
There's another part to the whole thing, which is that documenting of all the information required for the risk score is incredibly expensive. Because these are things like making sure you note down every single patient who had anemia. Or did this patient who you're seeing for stomach pain happen to have high blood pressure. If so, you get paid more, so therefore troll through their medical record, find every single instance where they might have had high blood pressure. And so there's like an army of people whose job it is to help keep risk scores high and increasing. And it's just sort of absurd that happens in the system.
That's exactly right. So there are a few problems with this. The one that we first started with was saying, because the benchmark is not adjusted and this referral process is adjusted, it's possible that the state could exceed the benchmark, have 10% growth, and we could have, in theory, 0 payers or providers referred to us. But the second problem is exactly the one that Dr. Cutler just raised, which is that the playing field is not level. Entities with more resources can and do invest quite a bit in auditing and coding compliance and making sure that everything is captured properly, which is not a bad thing. This is actual capture of diagnoses that are real and true for their patients. But some entities are much more able to do it than others, and we therefore, on our end, have no ability to look at the data and actually figure out if a higher risk score is indeed reflective of an older, sicker population, or if it's reflective of an investment in coding.
I can't resist. So remember our discussion about waste at the last board meeting, and the indirect implication, that waste, that expenditures, administrative expenditures are always wasteful, which I found a little troubling. But somehow that, and I don't want to just cast aspersions, but I think we need to recognize that somehow if we went to single payer, remember much of this is being generated by the federal government. You know, as the payers know, it may be expensive, but it's one of the biggest money generators for them. Because if you look at the amount of money that's flowing out of the Medicare Advantage payments because of the high risk scores. So this is a big issue. You raised it. And the other part of it is the general feeling that the risk adjusters are not great. We could do a better job. And I think it behooves those of us in the research community to continue to work on this, David. I'm sure a lot of people work with. This is a very troubling issue at a lot of levels.
I volunteer them all.
Okay. All right, get them work with our staff here and we'll get it. All right. But you know, I mean, I don't mean to take it. This is an area that, you know, we've seen some really strange numbers. You know, strange in the sense that you see risk adjustment growing by 10, 12% in 1 year. Now, come on. You know, the likelihood that that patient population of that group had so, yeah, because we're dealing with one contract, it's possible they move from A to B. So we're just gonna have to work hard to work around it where we can, and I know you guys are doing a great job trying to do that.
It's come up, David, so it's come up now in a blood pressure raising way at both the annual hearings and the committee meeting. So we can either address it or we can give all of us antihypertensives. One of them may be better, preferred to the other one. But clearly we want to follow this item.
It's on the list.
So we only have 2 more slides, both of which are just illustrations of this theme. The next shows an example. This is real data. It's a commercial book of business for one of the large Massachusetts payers. And what you can see is that from 2013 to 2016, unadjusted TME went up 16%, so about 5% a year. During the same time period, risk scores increased 9%, which means that the health status adjusted trend over the same time period looks like it's only 6% or about 2% a year. And so this would never be referred to us, and we would not have any ability to look at it under this process. Unless, of course, you know, the payer had another book of business that was referred, to your point, Dr. Altman. But this is, I think, exactly illustrating the true. The next graph I love, although it's certainly a little bit busy. So to orient you very quickly, each dot on this graph is a payer provider contract in a given year, so 12 to 13 or 13 to 14. And I think we've got 2013 through 2016, is that right? Illustrated here, so a couple of years of data. And importantly, when Ramsey was generating this, he threw out all of the contracts that had large swings in member months that were greater than 10%, so that we are not looking at wildly different populations from one year to the next. Above the dotted line are contracts that had health status adjusted TME growth greater than or equal to 3.6%. So those are the contracts that are referred to us. Below the dotted line are those that were below 3.6%. And then if you look at the quadrant, the problem quadrant, I like to call it, which is the quadrant in red on the right, those are contracts where, although the health status adjusted growth was below 3.6%, the unadjusted growth was above 3.6%. And the shape and color of the dots indicate the size. Large contracts being those orange squares. So you can see that this quadrant is full of all sorts of contracts, both large and small. It's also the quadrant with the greatest number of contracts in it, which I don't know is an accident. And when we break the data out over time, the percentage of contracts that fall into that problem quadrant has been increasing. Perhaps indicating that entities are becoming savvy and understand fully that it is in their own benefit to document diagnoses and complexity levels appropriately, and so that's been growing over time. This problem doesn't seem to be going away. It seems, if anything, to be getting worse. Anything else on this slide that I can help answer questions on? I know it's busy, but I do really think it helps visualize the problem. So that's the recap of the process. I think we've learned quite a bit.
Can I just ask you a separate question, and this may be for my fellow commissioners as well? So what you laid out here were several questions related to the kind of data and interpretation of the data and things that are troubling us about the data we receive and so on. There's a different set of questions, which is, have we learned anything about our process of doing PIPs that we should be revising in some way how we do it? That is, are there some things which are not going as well as we hoped they would? Are there some things that are going actually better than we thought they would, so we should do more? Like, sort of what should we take of our own process, our own as a state process for doing this, and any ways that we can do better?
So I will say that Ramsey does ask us, and we comply every year to do that on our internal process. Every year after we complete a list, we sit down as a team and look at what worked and what didn't. I think most of the issues we capture are very, very nitty-gritty workflow issues and are probably not the type of issues that you're asking about. I think that suggests we should do this process with a sort of external facing lens going forward. That being said, off the top of my head, I think the decision to do a comprehensive review up front and only ask follow-up questions of a very limited set of entities has worked very well. One thing we have made an improvement on is, as we've had 3 years of doing this process, and as we are finding that we ask some of the same questions over and over again, we have been trying to standardize the way in which we ask those questions and receive information so that we can start comparing the data over time and looking to see what sort of market-wide learnings we can pull out of that, whereas in the beginning it was much more, give us what you have in whatever form you have it. Kate, Ramsey, any other thoughts?
So one thing, so I wanted to highlight actually both the positive and some of the things that I think are challenges. So one thing that I think it's a little tricky to see because so much of this process is confidential by statute, is that I think the process has been much more successful than candidly I would have suspected it would be without having done a PIP. So these conversations with payers and providers are incredibly enlightening, and I hope that that's something, a sentiment that's shared by the commissioners. And in many cases, we have been able to get kind of behind the scenes agreements on certain pieces where we have identified concerns, but they haven't quite risen to the level where it was deemed necessary to do a performance improvement plan. I think that process, in terms of actually encouraging folks to really take a very close look at what they are doing internally to control spending, has actually been quite effective, even without going down the process of doing a PIP. And so I do want to highlight that. I think some of the core challenges are some of the things that we've highlighted already. So the timeliness of data is always a core challenge. And coupled with that, I think, is something that also Kara highlighted, which is that many of the payers and providers that we've had before us have highlighted things that sound phenomenal on paper that they're doing to try to control spending, control utilization. The data that they can actually show us, showing that those have been successful, has by and large been incredibly limited. And so that has been tricky from our perspective, and something that in particular are working with folks across the agency to figure out how we can better encourage payers and providers to be robustly tracking information on their own care delivery improvement efforts, to really robustly show that they are indeed achieving the savings that they are hoping to achieve. If commissioners want to add, I would love to hear your perspectives on how this process seems to be going.
Well, I'll just start off by echoing the comments, which is that, Kate, I think you said something which is super important, which is that these conversations have been helpful, both to us, that is, they've been helpful to me in understanding things, and at least if what the organizations tell us is truthful to the organizations as well. That is, they say it's been helpful to be pushed on what's going on here, and are you, what will you be able to see here, what are you not seeing here, and so on. And so that's been helpful. I would say my two areas in which we may want to consider making changes, maybe we should consider strongly. One would be this issue about potentially changing the legislation in terms of what's referred to us, or recommending to the legislature, I should say, changing the legislation in terms of what's referred to us, because I think that really is a difficult issue. And then the second is maybe we can talk with Chia about what are the sort of computer and processing limits to how rapidly we can get data. That is, there's a run out, and you can't do things until the run out are done, and then it's done. And then given that, how could we set up a process structured around that date so that we can act as quickly as we can after those data are
I think there's absolutely no negative to the process. It's only positive. And in terms of the data, there are definitely things that we can do with Chia to move that forward so that we can get data that we can rely on. And I think that would be far more effective. In terms of the risk scores, looking at everything from coding, there's a whole process that goes into that prior to getting a risk score. And that's something that I think we really need to look at in terms of how can we most effectively manage that process.
I'll just comment on being part of this committee and therefore part of the review process, which is done in private, so obviously all of you are privy to those discussions. It's very thorough and it's very professional. I do want to compliment the staff for the review that we do. We as commissioners look at all of the referrals, initially, we identify ones where we want additional information, we then have a second review, so, and it's been very informative, interesting, and I do have to compliment the staff for helping us get through what could be a very complicated and data deep process, so thank you all.
Stuart, do you want to jump in?
Yeah, no, I first of all, I want to echo what was just said. You know, this is one of the unseen, I wouldn't say powers, but one of the unseen parts of the law that really make the whole system work. And could be, and probably will be even more important going forward. So I want to echo the idea that we're very pleased with the level of detail and the professionalism with which the staff take it on. And as Kate, you pointed out, the fact that the payers and the providers do take this seriously, I think attests to the fact that most of the entities within this state want to make this thing work. So, but I think we've laid out the issues, and we may need to look at legislative changes to make the process work better. And I have a feeling that, well, you never know, controversy comes all over the place, but a lot of these are just to make it fairer and actually help the entities so that they don't have to come in after the fact and give us information. So this was a very helpful discussion.
Elizabeth, I want to be mindful that just because you're not physically here doesn't mean you don't have opinions as well. And so I want to give you a chance.
I would add one point, and I think this is, to give credit where due, Dr. Kreider's raised some, I think also like made about looking further at risk scores, looking whether we have flexibility within the current. Can you hear me?
Yes, we can. We're just trying to project you over a microphone into the room.
Okay, sorry about that. I think looking at, as Kate mentioned, there's flexibility within how we do the risk adjustment within the law now, and comparing that and doing some more analysis to determine whether we would need legislative change. The other point I make is Dr. Kreider's raised this before, but I think we should also look at collection of information about the number of full-time employees or employees doing the billing and coding work as a way to kind of quantify the disparity of the resources put towards within organizations. So those are the 2 points I'd like to make.
Thank you. Let me ask Kate and Kara if on the health status component, can you draft some either recommendations or some possible directions for the next meeting of the committee? To say either we as a staff have spoken about it and we recommend that the commission do this, and first obviously this committee would be the right place to do it, or we're not sure what to recommend, but here are 3 options that might address what the committee has spoken about, and then maybe we can schedule this for the next meeting of the committee. Follow up on that particular issue.
Great.
And then I think on the data issue, if I don't know that we need recommendations so much as if you come back and brief us at some point as to what would be ways that we could streamline, if at all, the timing in ways that the data could be as close in time as possible to it. That would also be helpful. But I think particularly on the first one, thinking about we recommend you do X, or we think there are 2 or 3 ways you could go, which way you commissioners would want to go. Thank you.
Thank you.
We also want to discuss the cost trends report. And so
Laura, you can start stuff.
Yes,
Okay, thank you so much.
great. Great to be here. I'm very excited to reveal some of our findings for this 2018 cost trends report. We are going to be discussing variation in hospital admission from the emergency department today. So talking about the emergency department is not new for the HPC. We have focused before on overall emergency department utilization as well as potentially avoidable ED utilization. Those have both been focuses. However, this is a different look at emergency department use. We're looking at emergency department visits that convert to what we're calling inpatient admissions or admissions. Emergency department is a main gateway to inpatient inpatient admissions. Nationally, depending on what literature you read, you see that 11 to 20% of ED visits result in admission, and about 50% of the inpatient stays originate in the emergency department. The reason we're interested in this, in particular, is there's a cost perspective. Inpatient admission roughly costs about 10 times or more than an emergency department visit, and there may be an opportunity for reducing unnecessary inpatient stays here. This has come to our attention through a couple of means. One is there's some literature highlighting that there's vast variation by condition and by hospital in the rate of inpatient admissions from the emergency department. And then also recently, as recently as September actually, there was a lawsuit that was settled around quotas, this was in Florida, around quotas requiring in a hospital setting, asking for admissions to the EDs to have a certain rate. So both those, the literature and some of the news coverage has really brought this to our attention, and we wanted to look within Massachusetts. In this presentation, we're going to talk about variation in admission by hospital type, and condition. And again, we're really looking to understand, is there a potential for reducing unnecessary inpatient stays? So why would somebody be admitted from the emergency department? There are obviously clinical factors such as the severity of the illness, which we don't have much control over. However, there are provider hospital level factors as well as social factors that there may be policy or programmatic levers. Specifically, I want to highlight that service availability and on-call coverage might be a factor at the provider or hospital level. We have also heard that bed availability, whether it's lack of beds or a lot of beds, may also influence the decision to admit or not admit somebody from the emergency department. In terms of social factors, whether or not a person has a strong connection to a primary care provider that they can immediately see or shortly see for follow-up after a visit to the ED does factor into emergency physician decisions about whether to discharge or admit a patient. Some of these social factors, we talk about this in post-acute care as well, that the home health services or other links could be, other programs or policy levers like that could potentially influence these some of these social factor decisions. So we think that this is an area ripe for exploration. I want to talk a little bit about how we approach this study before I turn it over to Leiden for reviewing our results in more detail. So for this study, we were primarily presenting results from the 2016 acute care hospital discharge databases. We also looked at 2015 for these analyses to make sure that whatever we were looking at was not, a one-year aberration. And we'll talk more about that later. We're using all three databases here. We're using the emergency discharge, observation stay, and inpatient. And I just want to lay out that the observation stay database captures observation stays, which are kind of intermediate status. They're a status, not necessarily a place.
And the observation status really allows more time for clinicians to evaluate and treat a patient without admitting. However, there's some literature that suggests that observation stays are substituting for short inpatient stays, and they are more costly than just an emergency department visit. So that's why we included them in this study. We did do our best at adjusting for different patient characteristics. We have our usual gang up there of age, gender, race, payer. We also added a drive time to the nearest ED because we thought that might also influence a decision about whether or not to discharge or admit. And ultimately, we're trying to answer some of these questions below on the third arrow. I'm not going to talk to all of them right now, but we're really trying to understand at this initial foray the variation that we're seeing, or to explore and illustrate some of that variation. The next slide is here just to highlight what is the world that we're talking about. And so for this initial study, we're looking at just medical emergency department visits. So about 68% of the 1.7 emergency, 68% of emergency department visits are medical, and that represents about 1.7 million emergency department visits. So I'm gonna talk about our key findings. We found that about 23% of all medical visits in Massachusetts result in a transfer, long observation stay, or inpatient admission. That's a little bit higher than the national average, but our definition is more inclusive than the literature that we were looking at, and I'll explain why in a minute. Admission rates by individual hospitals vary considerably from 13 to 32%, so that's a finding. But we had to delve a little bit more and say that within each condition or condition classifications, there was sometimes little variation, so someone with septicemia was likely to be admitted, as well as, there were other conditions where there was significant variation, which we'll illustrate, such as COPD. Yes?
On the 13 to 32%, do you find that, for example, community hospitals have a significantly different rate than other hospitals? Was there any?
So for the overall all medical, which I won't talk about, the differences we did not see differences AMC teaching or significant differences AMC teaching in community, which we found interesting. We did find that hospitals with high admission rates for some conditions had high admission rates for other conditions. And we'll talk about the last point in more detail at the end, but we also wanted to make sure that, we're not taking a stand right now and saying low admission rates are better, because we want people to be appropriately admitted. But one of the things we did want to look at is, did hospitals with low admission rates tend to have more revisits, or were their revisits the same? And we found that hospitals with low admission rates did not tend to see more frequent revisits.
Although, this was a great study, by the way, but in a funny sort of a way, you might feel good if all the ED visits were admissions, because that would rule out a lot of unnecessary ED visits. So it flips itself around. A lot of our discussion is, why did you go to ED? I mean, you could have done, and you weren't that sad.
Yeah.
So we need to be a little careful.
Yeah, we're cutting it both ways. So I want to talk a little bit more about our definition and how it varies a little bit. We took the 1.7 million medical emergency department visits, and we saw about 15% of them resulted in a direct admission. To the point about community hospitals, a community hospital emergency department, or just a less well-resourced emergency department, might have to transfer somebody to another emergency department. We didn't want to penalize the emergency departments or hospitals with more resources for receiving sicker patients. We weren't actually able to control for patient comorbidities in the study, so what we did was said, if you were transferred out, you were a sicker patient, and you should actually count against the first ED you showed up in. But that only actually makes up about 2% of our population. And then we also included observation stays. Specifically, we looked at stays over 48 hours, and there's some literature to suggest similarities there with inpatient admission. So we get to our overall admission rate of 23%. And with that, Leiden is going to review some of our results in more detail.
Thank you, Laura. So to kind of talk a little bit more about that first goal that you mentioned, which is to assess the amount of variation that there are for these ED admission rates. And we will look at them by hospital, but here I want to kind of start by diagnosis. The fact that there is a lot of variance for these admission rates. And box plots are one of the ways that we can kind of visually see quickly how much variation there is. If you look on the left, there's a little example of how box plots are set up and calculated, with the top of the box showing the 75th percentile and the 25th at the bottom, and this kind of gives us a sense of, where most of the observations are for a given condition, or if we were to look at this by hospital, we'd be able to see that as well. The lines kind of show us, the extremes, and then further the dots show us the really extreme outliers, as Dr. Cutler mentioned earlier. Sometimes outliers can have a big effect, and so it is important to note that there are some outliers. There's about 4 conditions here that have outliers, and we did not make a formal assessment in that respect, but I think the variation we're going to show today bears itself out, and we'll show you a few validations, a few checks on those. But just to show you quickly what we are seeing by condition, if you look on the left, there are conditions like septicemia, sepsis, as Laura mentioned, that there isn't much variation, and most of the variation here is clumped between 96 and 98%. Again, there are some outliers, as you can see there. And then if you look at a condition such as COPD, it's the box is much wider, and you can see below we have listed what the difference between the percentage points between the 25th and 75th percentile for these conditions. And COPD has 2 percentage points that are part of that variation, whereas COPD has 21 percentage points. So there are very wide differences, and this is just a selection of conditions, but this starts to show us the variation we're looking at. The next slide here is going to get at why we felt that we need to do a patient adjustment. As Kara mentioned earlier, for health status adjustment, it's important to kind of get more to apples. When we're looking at these rates, and we don't want to penalize anybody based on their patient population, and we mentioned the factors that we do adjust for, which are age, gender, race, payer, income, and patient drive time to the nearest ED. So this slide here will show the effect of that patient adjustment. The bars in the blue are the unadjusted admission rates for the top 25 hospitals by ED volume. And if you look, the orange bars show the effect of the adjustment. And you can see that even there are some cases where the rankings would be reshuffled by that patient adjustment. And we feel like this is a more apples-to-apples picture of that variation in rates. And this one in particular is just for pneumonia, but we'll show you some others as well.
Can I just stop you for a minute and go back to the previous slide? First, as I said, I found this information really fascinating. So, this is probably worth spending a little more time on, maybe not necessarily today. So you take chest pain, for example. So on the one hand, everyone gets chest pain and immediately have a heart attack, they think. So it's not surprising that they immediately run to the hospital, and it turns out it's gas and it's whatever, and it's not a big deal. So it's both not surprising that this is a low admitter, and not surprising that people run to the hospital when they get it, the ED right away. Whereas sepsis, on the other hand, when you go in and you've got a bit infection, you know you're sick. And the same thing with CHF, and abdominal is close to. So it'd be interesting, as you sort of delve into this chart, which would affect maybe the hospital where somebody goes in the first place. You mostly, if you have chest pain, go to the closest hospital, which is more likely to be a community hospital than an academic medical center. You may get referred if you're really sick. I'm just thinking as I thought it through. There might be a lot more information here worth analyzing.
Absolutely. And I think we'll show, there's some overlays a little bit later with the different conditions. And we also show different categories of hospital. I think you can kind of see that there's some patterns that are specific to those. We
might want to engage in some kind of public education campaign. This is really when you're concerned if this happens but not that, so as to reduce the amount of questions.
Yeah, Chair Altman, to your point, I just want to highlight again, this is the first time that we have looked at this, and I think to our knowledge, the first time that an analysis like this has been done in Massachusetts. And so I think like many times when we first do one of these analyses and we see a lot of variation, I think we're always careful not to necessarily make a direct judgment call. This is bad, that hospital's bad, this hospital's good. But really, to use this as an opportunity to engage in some of those further conversations. And we've had some of these conversations with the emergency physicians, but I do think, this is a new area for us to look in, and I think an area where we want to talk to some of these hospitals, talk to emergency physicians. What is the discretion that is being put in place? How are some of these decisions being made? And in places like a COPD where there, appears to be a lot of variation kind of in the middle there, are there better clinical standards that we should be thinking about? Are there better supports in the home, using technology in different ways? So I think this really is a presentation that is supposed to kind of spark more questions maybe than answers.
That's great.
Thank you, guys. So we went over this to just show you the fact of the patient adjustment. And so everything I'll be showing after this is going to be adjusted. Because you're going to have that patient adjustment. So the next slide here, actually at the bottom, shows all medical rates, the all medical ED admission rates for the top 25 hospitals. And they're sorted from left to right, from the highest to the lowest. What we wanted to also be able to answer is, are these patterns, do we see these patterns throughout? Is it, we're looking by hospital, we're looking by condition. Do hospitals that tend to have higher rates also tend to have, for all medical, tend to have higher rates for other conditions? So here, above, we have plotted congestive heart failure and pneumonia. With congestive heart failure, the box is in orange, and pneumonia with the diamonds in blue. And you can see that there's, when you look left to right, there is a pattern where the highest ED admission rates for a given hospital are associated. There seems to be a pattern for CHF and pneumonia with the higher rates for those as well. And we also highlighted in yellow the bars that are for the academic medical centers that you can see. And so a little bit later I'm going to show you how it looks, patterns that we see for those hospitals. But you can definitely see there's appears to be a trend here. And we're going to look at that a little bit closer here with this these correlations. This allows us to kind of give us a sense of how strong are these relationships. And here we've done an array with different conditions and how strong are the relationships for a given condition in a hospital with another condition. The boxes in blue or in gray there actually highlight where there is a strong association for a given diagnosis with another diagnosis. And you can see there are a number of conditions where these rates are strongly correlated. And we continue to kind of take that lens, looking at year to year, as Laura mentioned. We wanted to make sure that this was an anomaly of 2016. And so here what we have is for two different selected conditions, pneumonia and chest pain, 2016 and 2015 rates. And you can see that strong association still holds out, 0.7 on the left and almost 0.8 on the right, with that strong positive association, the relationship of those rates moving together in multiple years. And as I mentioned, I wanted to take a lens of is this something that's a factor of the type of hospital. We do our patient adjustment, but still, do we see different rates when we're looking at community AMC? Though we don't tend to see a big difference between their all medical rates. You can see something like pneumonia and chest pain, where the AMCs even have a lower admission rate, and so there's not a clear picture, tying these higher admission rates to a type of hospital. Here again, not to dwell on this a little bit, but we thought it was important to show how our definition of an ED admission is comprised for these hospitals as well. So the blue bars at the top and going down are OB stays over 48 hours, then the transfers, then the OB stays that were then admitted to the inpatient unit, and then the direct inpatient, the admissions to the inpatient unit. And we can see that as part of our definition, community hospitals were less likely to directly admit, but then we're still slightly more likely to admit, to transfer patients out to other acute care hospitals. So there is a difference in this composition, but largely, as far as the overall rates, they're pretty close when you look by type of hospital. A final kind of validation for us to make sure, to see how the patterns fit. When we start with a given pattern, do we see this? Is it reliable? Is it reasonable? Is it stable? We wanted to look at almost a sense of quality, or what is happening to these patients, and when they are discharged from the ED, are they returning? Are the higher rates associated with that, or the lower rates associated with that? So this graphic shows a 7-day revisit rate, and this is a patient that has been discharged and then would return to the ED, inpatient, or observation unit. And this again is just for the 25 largest hospitals. What we did here was group it by quintiles of those admission rates. So we have from the left to right, quintile 1 through quintile 5. And here we've just shown chest pain and pneumonia. And with this graphic, we can see that there we do not tend to see higher revisit rates among these patients. So quintile 1 on the left, we can see that there are that hospitals that admit the fewer patients from the ED do not tend to see those higher revisit rates necessarily. And with that, I'm going to return it to Laura just to kind of.
Great, thank you, Lyden. As David mentioned, and as we talked a little bit about, this is really our first exploration at looking at emergency department visits that result in an inpatient admission. When we met with stakeholders, some of the conversations we had was just about how informative it was just to see the variation, that the drasticness of some of that variation, ranging I think from 9% to almost 80%, or adjusted 20% to almost 80%. And so just bringing that out there and saying there is this variation. There's some similarities here with our post-acute care work where we're seeing a lot of variation, but we don't have an answer for it. But putting out that variation it really starts a conversation.
So this is fascinating. I think you were wise to bring it to the stakeholders, and in particular to the payers, because there is like some literature on what happens when you start down this path. So like if you go to the upper hospitals, the upper institutions on that chart, and you say, why are you so high? Almost invariably, like literally almost invariably, they give you the same answer, which is, of course, my patients are sicker than average. So naturally, they're admitted more. And it turns out to be a well-established mathematical fact that the average hospital has patients that are sicker than average. It's just, in fact, it's actually almost a universal fact, which is that every hospital has patients that are sicker than average. So if you want, so the next thing that you then do is you say, okay, so let's show this to you. I want to show you that your patients are not sicker. So, but then you like have to actually convince them by going through in detail and showing them. And so I think that, and that can all be done, but I think the payers have to be on board with that because they're the ones who are going to have to go through and say, no, see, look, based on every clinical condition we know about, your patients are actually not sicker than average. Your patients are average sickness, and you're just choosing to admit them more. And then after that phase, you can then get people to open up and actually discuss, that may be right. We may be having a different threshold for our admission decision, because it's clearly, as you showed a couple slides later on, it's across the board. It's not just one hospital with one condition, another hospital with another condition, and so on. So this is, I think, well worth doing. It's well worth doing here. It's well worth doing on the post-acute and so on. But it tends to need more than just putting it out there to make it work, because there's a first obvious answer that you almost always get, which ends the discussion unless you're willing to continue. And by the way, that answer is wrong, because my patients are universally sicker than average. But you still have to get past that in order to get a significant impact.
So let me, again, this was really great. I found it really fascinating. So there are a lot of other variables that if you assume you're going to dig further, that just off the top of my head and just want to think about. One is, again, that the ED is often used as an extension of our basic outpatient system. Whether that's a good thing or a bad thing is very debatable. Generally, we tend to think it's a bad thing, that if we had more primary care and more physicians out in the community and they were open more. But on the other hand, there is a counter argument that they're really geared up to do it and let them do it. So I've been part of this debate for a long time. So you're going to see significant variation. As I said, just think of you as a potential patient. As I said, if you get an onset on something you didn't really anticipate, either you're going to go to the closest hospital, or the ambulance is going to take you to the closest hospital. So then the question is, when you get there, who's there? And let's face it, the capacity and the technology of EDs really varies tremendously. And as somebody once pointed out, just because something says it's a hospital doesn't really mean it's a hospital. And the variation is great. So the ability of an ED to deal with a patient varies. And so if they got essentially they got 4 choices. They can send you home. They can continue to treat you with the ED. They can admit you into the hospital, or they can transfer you. And it's going to vary depending upon how sick you are, but also the capacity. So you're going to have to look into that. And it's not necessarily a bad thing. And actually, an ED visit is actually the most expensive side of the healthcare system. So on the one hand, the per day costs staying in the ED is much more expensive than if you go and you put in. So to some extent, moving them out of the ED into the hospital is a cost saver, but then not, depending on how long you stay. So so at the end of the day, I mean, one of the criticisms of the U.S. health system has been the fact that we have much more ED than other countries, and B, we have much more ICUs as well. All I'm saying is that, as you pointed out, this is the beginning of a really interesting study, and everything you've laid out really is good stuff.
Thank you, Commissioners.
And I would just add to that great point, Chair Altman. When we had talked to some of the emergency physicians and have had conversations with them about analyses that we've done on avoidable ED or patients arriving at the ED, they have reflected a perspective to us that they don't have control over the patients that arrive in their doors. But what they do have some control over is whether those patients are admitted or whether they can really provide good quality care in the emergency department and discharge those patients to home, and do feel like that they have some agency in that role. And so I do think even they would say there are areas for improvements across emergency departments in their ability to provide that great level of care and be able to appropriately make those decisions one way or the other. The other thing I would add, and kind of reinforcing the complexity of this issue, is something a little bit more anecdotal from our experience with the CHART program. And now the CHART program tended to be focused on behavioral health patients, and those were excluded from this analysis. But what we did hear from some of those programs was where, through the CHART program, where we had really robust teams of professionals that were going to follow that patient back to the home or back into their community out of the emergency department, that the emergency physicians had a much greater level of comfort in knowing that if I discharge this patient who maybe has is still needs some level of follow-up care or monitoring, that there's going to be someone back in the community, a nurse, a community health worker, someone who's going to go to that home the next day and check on that patient. And that does inform some of these decisions about the safety of the patients. And again, it's a little bit of a different story than this analysis here, but I think it does raise some of these questions around, well, if some of these hospitals or health systems have really good home health partners or visiting nurses or other organizations that they know can go and provide that follow-up care, that may be a good thing for the patient and a good thing in terms of total healthcare spending. Even with maybe an additional home health visit attached to it, it'd still be potentially money saving than having to admit that patient and have that patient be in the hospital for a few days. So complex issues here, and I think we're excited to engage with other experts on this as we move this forward.
Yeah, and maybe that this will catch up with our discussions that we've had on post-acute care use, which have many of the same similarities. I think we'll probably come to, but I suspect at the moment Commissioner Cohen is going to declare as stealing facilities which are not appropriately owned. So let me then move to adjourn the meeting. Thank you all.
Thank you.